Welcome to AETCM, the emergency medicine channel. Today we are discussing about a case which is admitted yesterday. So Dr. Sujit will be telling the details of the case. Can we start?
Yes, sir. Presenting the case of Mr. Sukumaran, is a 92-year-old gentleman hailing from Kozhikode, who is a retired officer. His date of admission was 10/5/2020, date of examination 10/5/2020. His presenting complaints were fever for last 3 weeks, followed by fatigue for last 2 weeks. History of presenting illness: the patient was apparently normal 3 weeks back when he started developing a fever that was insidious in onset, more during the evenings and night, associated with increased sweating.
Can I interfere here?
Yes, sir.
What are the conditions you get evening rise of temperature?
So tuberculosis,
Okay.
Hodgkin's lymphomas.
So these are the two important conditions. Tuberculosis is a very low grade fever, lymphoma high grade. Both occurs in the night. Please continue.
It was a low grade fever with a maximum temperature noted being 100 Fahrenheit. The fever was usually relieved by taking antipyretics, and it was not associated with any chills or rigor. There was no history of any throat pain or cough, no history of any recent travel, no history of burning micturition or abdominal pain, no history of any palpitations, syncope.
This 90-year-old male patient coming with fever with chills. You are told there is no chills.
No.
Suppose there is chills and rigors. What are the differential diagnoses?
So first I'll suspect urinary tract infection.
That's most important.
Then any viral infections.
More than viral, malaria we should suspect.
Malaria.
Viral is okay,
viral.
But malaria. But urinary tract, as you said, it is the most important. Please continue.
Within 1 week of onset of fever, the patient also complained of increased fatigue. It was progressive, and by the end of 2 weeks, the patient found it difficult to do his normal activities, which was basically the normal activities he will be doing within the house.
Okay.
The fever was still persistent at this time, and he also complained of an associated weight loss. He lost over 10 kg in the last 2 weeks.
What is a significant weight loss?
More than 10% of body weight in the last 3 months.
Okay, please continue.
Moving on to past history, the patient did not have any similar occurrences in the past. Regarding his medical comorbidities, he is a known case of systemic hypertension for the last 15 years and he is on antihypertensives. There is no history of any diabetes mellitus, no history of any dyslipidemia, no history of any tuberculosis, bronchial asthma, coronary artery disease in the past. Past surgical history, he did not have any surgeries done in the past. Moving to personal history, the patient has an adequate sleep pattern. He sleeps for around 6 to 7 hours every night. His appetite is reduced for the last 2 to 3 weeks. His bowel and bladder movements are normal. He is not habituated to smoking and is non-ethanolic.
Okay.
Family history, there are no relevant family histories. There were no history of any tuberculosis or any malignancies in the family. He did not have any known allergies. Moving on to general examination, sir. The patient was...
Do you have any differential diagnosis now after history?
Sir, it looks like a fever without a focus.
But somebody is having fever for last few days, a significant weight loss is there. What are the common conditions you suspect?
Malignancies.
Okay,
lymphomas.
Malignancy at this age,
Malignancies are very common. Tuberculosis.
Tuberculosis is another important condition. Since he has evening rise of
temperature,
weight loss, tuberculosis is one of the most common differences. Please continue.
Patient was alert, conscious and oriented to time, place and person. He was examined after obtaining the consent. His vitals were pulse of 74 beats per minute, regular, normal volume and character, thickening of vessel was present, no radial or radiofemoral delay, and the peripheral pulses were felt equally and bilaterally. His blood pressure was 140/80 mm of mercury, measured in the right arm in supine position using a standard adult size cuff. His respiratory rate was 26 per minute. It was regular and abdominal thoracic pattern.
Okay.
His temperature was 98.4 Fahrenheit. Moving on, he had pallor. There was no icterus, no clubbing, no cyanosis, no lymphadenopathy or edema.
Can you define cyanosis?
Cyanosis is when there is reduced hemoglobin in the blood more than 5 gram per cent.
So patient have bluish
discoloration of skin.
Hand, skin, mouth
and all. Examination. Moving on to the examination of respiratory system. First, the upper respiratory tract was examined. Nose, there were no nasal discharge, no deviated nasal septum or no nasal polyps. Throat, no inflammation or granulation seen. Paranasal sinuses, there were no tenderness.
Okay.
Moving on to lower respiratory tract examination. On inspection, the trachea appeared central. The accessory muscles of respiration were not used for breathing.
If trachea is deviated to one side, what do you suspect?
So it's either the mediastinum is pushed towards one side or pulled towards the same side.
Okay. What are the conditions which can pull the trachea towards same side?
Pulling can happen if there's any lung fibrosis or lung collapse.
Okay. Upper lobe collapse.
Upper lobe collapse.
Okay.
Pushing
outside.
Pushing outside happens if there's a pneumothorax or pleural effusion on the opposite
Okay.
side.
And where there is a volume expansion,
Volume
it
expansion.
may pull to opposite
Side.
Volume loss, it may pull towards
same side.
Okay. Please continue.
The apical impulse was not visible on inspection. Shape of chest appeared.
What is the condition you will get absent apical impulse?
So one, if the apical impulse is behind the rib.
Okay.
Two, if there is any pericardial effusion. Pleural effusion.
Obesity.
Okay. There was no supraclavicular hollowing, no infraclavicular hollowing or fullness.
Okay.
The movements appear to be
If there is supraclavicular and infraclavicular hollowing, what do you suspect?
So there's a lung volume loss at that point.
Volume loss. Like fibrosis,
collapse.
Okay.
The movements appear to be reduced on the right side.
Okay.
There was no drooping of shoulders, no kyphosis, no scoliosis, and no chest wall abnormalities.
Okay.
Moving on, palpatory findings. The position of trachea was central.
Okay.
The apex beat was palpable at the left fifth intercostal space, 1 centimeter medial to the midclavicular line.
Okay.
Chest diameters. AP is to transverse, anteroposterior is to transverse diameters was 25 is to 32 centimeter. His chest circumference was 108 centimeter. Left and right hemithorax were equal, 54 centimeter each. Chest movements on examination appeared to be reduced on the right side.
Okay.
The chest expansion overall was 4 centimeter. On the left side, hemithorax expansion was 2.5 centimeter. On the right side, hemithorax expansion was 1.5 centimeter. Vocal fremitus was done and it was found to be increased over the right infraclavicular and interscapular areas.
So there is a volume loss on the right side, but the vocal fremitus is increased.
Oh. Moving on to percussion. Impaired notes were percussed over the right infraclavicular and interscapular areas.
Okay.
The other areas were normal.
Okay.
Liver dullness was percussed over the right fifth intercostal space at the midclavicular line.
Okay.
Trough space was resonant. Tidal percussion had no significant finding.
Okay.
Auscultation. The patient had bronchial breath sounds over the right side, especially over the infraclavicular and interscapular areas.
What do you mean by bronchial breath sound?
So the inspiration followed by a gap and expiration.
Okay. Okay, continue.
The vocal resonance was found to be increased over the right infraclavicular and interscapular areas,
Okay.
and fine crackles were observed over the right side in the same areas.
Okay. So you get a volume loss on the right side upper part. There is a reduced breath sounds, but bronchial breath sound is there. Percussion shows a dull note. So what do you think on the right side apical part?
So that looks like a fibrocavitary lesion.
Why not a consolidation?
Consolidation will have
consolidation will have equally same finding.
Yes.
Only thing duration is
duration is more.
Here it is long duration weight loss. Suppose the patient come with the acute onset of breathlessness, and if you get all these findings, you should
have
suspect
a consolidation
with bronchial breath.
Yes.
Since it's a long standing with some crepitation, percussion impaired, you can suspect a fibrosis. But the consolidation should be kept as a differential.
Okay, sir.
Okay, please continue.
The other system examinations were normal.
So this patient will be taken inside the hospital. What is the first priority? Is airway, breathing, circulation should be checked.
Checked, sir.
Everything is normal.
Yes.
What investigation you want at this point?
Sir, immediate investigation, as in significant investigation, would be a chest X-ray.
Okay, what is the chest X-ray finding in this patient?
There will be patchy infiltrates, calcifications.
So this patient, what is the finding?
In this patient, there will be consolidatory findings over the right
so
side,
there is some
upper lobe.
Upper lobe infiltrates are there. We'll show the X-ray. That is there.
Yes, sir.
Okay. What other investigation you want?
Starting from basic blood investigations, I'd like to do ABG, complete blood count, CRP and ESR, procalcitonin.
Okay.
And then moving on, I'd like to do serum electrolytes because it's a chronic, subacute chronic condition. Then if I'm suspecting pulmonary tuberculosis, I would like to do a sputum AFP culture sensitivity.
So this patient has got 3 AFB samples, 2 are positive. Will you consider tuberculosis in this patient?
I'd like to do more investigations on the patient. Gene expert CB-NAT can be.
Okay, so we'll do gene expert. That is also positive.
Okay, sir.
Rifampicin sensitive.
Okay.
How do you treat the patient? The patient has got a 10% weight loss.
Weight loss.
Patient has got a right-sided lesion. Patient is having gene expert positive. And it is rifampicin sensitive. How do you treat this tuberculosis?
So if it's rifampicin sensitive, then I'd like to start with first-line anti-tuberculosis drugs. The drugs are isoniazid, rifampicin, pyrazinamide, ethambutol.
Okay, what is the dose?
Dose of isoniazid is 5 mg per kilogram. Dose of rifampicin is 10 mg per kilogram. Ethambutol is 15 mg per kilogram.
Okay. Then one more drug, pyrazinamide.
Pyrazinamide, 25 mg per kilogram.
So 5, 10, 15, 25.
25.
So how will you start? So today I want to start ATT. So how long I have to continue the 4-drug regime? So
there are the 2 phases, intensive phase and the continuation phase.
Okay.
The initial phase is 2 months and the continuation phase is 4 months.
Okay. So initially 4 drugs should be given for
2 months and 2 drugs for 4 months.
Okay. Suppose the patient come for review after 2 weeks or 3 weeks. What are the investigation you will ask during that time?
The significant investigation would be a liver function test.
Okay. So because rifampicin and pyrazinamide can alter the liver.
Yes, sir. Then along with normal blood investigations.
So you want to do AFB afterwards, sputum AFB?
Yes.
Okay. Why you want to do AFB? Normally, after 2 weeks, we may not do an AFB test. If you want to do an AFB, you should go for a culture.
Okay.
Because AFB, even if after treatment, the bacteria may remain.
Okay, sir.
So you may not immediately ask an AFB, but you can see whether the infectivity has come down or not.
Okay.
So we can be more careful.
Okay, sir.
But most of the time it will be present.
Okay.
Okay. So after one or 2 months, patient is coming again.
Okay.
Then AFB is very important.
Okay.
What you will want to do? Suppose again AFB is positive. What you do? After 2 months also AFB is positive.
I have to do a CB-NAT again.
Again you have to go for culture. Culture is very important. Culture sensitivity.
Okay.
So there you want to see whether the patient has gone for a multi-drug resistance. Initially it was not picked up, but later it can pick up.
Yes, sir.
So we have to, if it is positive, then you have to do it. Otherwise, routine treatment is enough.
Okay, sir.
Okay. What are the complications of tuberculosis?
Complications of pulmonary tuberculosis could be tuberculous pleural effusion, lung collapse, an aspergilloma, a bronchopleural fistula, malignancies.
Malignancy is not very common in tuberculosis, but somebody is like old age, he can have malignancy. On top of that, he can have pulmonary tuberculosis. But other cavitary lesions, fibrosis, in that fungal infections are very important. Suppose he is diabetic.
Okay.
What are the complications of TB and diabetes? What problem can occur? So TB will not be controlled if the diabetes is not controlled. It is a problem.
Okay.
Any other area you want to check? Suppose he is having a lymph node.
Yes.
You want to check it?
Yes, sir.
What is the importance of examining lymph nodes in this case?
The secondary tuberculosis in the lymph nodes can happen.
But, you should think that it's an apical lobe lesion. It can spread to your
cervical lymph nodes.
So your examination part will be very important.
Okay.
Okay. You want to take a bronchoscopy for this patient?
Yes.
Why you want to take? As a routine practice, it is not recommended because we are getting a AFB positivity. Suppose you are not getting an answer for the disease, then you may require bronchoscopy. Otherwise, routinely bronchoscopy is not required. What is DOTS therapy?
A daily observed treatment.
This is recommended by central government. Yes. So that should be done by a ATT center.
Okay.
Thank you for your nice presentation.
Thank you, sir.